All good.
Great. Um, well, welcome everyone this evening to the Skull Base Society webinar for this occasion. I'm very happy to introduce a couple of good colleagues of mine, Dr. Richard Mannion and Dr. Martin Wood, who are both neurosurgeons, skull-based neurosurgeons that I've known for a long time. But really, what this webinar is about, it's about decision making in skull-based surgery, and it's something that we all do and we do it on a daily basis. But I think there are some principles that go with it that are important, I think, to emphasize and help to crystallize our thinking and also the way we make decisions about our patients. And it's also about tailoring the right approach for the patient rather than what the approach is that we think we can do best. So, Richard, I'm going to start off with you. Uh, Richard's a neurosurgeon at Addenbrooke's Hospital in Cambridge. He did a fellowship here in Brisbane way back when, and he's gone from strength to strength since then. He's going to also tailor a little bit with Martin, who also did a fellowship there in Cambridge and also in France, and has come back and worked in both adult and paediatric neurosurgery. So, Richard, without further ado, thank you very much for giving your time up today to speak to us.
It's a pleasure, James, and welcome everyone, and thanks for the invitation. So, this is an evolving field. It's different now to how it was 10 years ago, and it's likely to be different in another 10 years because of things that change. But equally, there are many of the fundamental principles which are consistent. Now, when I started as a consultant around 15 or plus years ago, I would go to these international meetings, and I noticed two things that I thought I would share with you. So, the first one, which I call International Skull Base Meeting Rule number one, is that you would go and sit in talk after talk after talk of people putting up these slides of really difficult looking tumors. This is a petroclival meningioma, which is arguably at the top of the tree in terms of difficulty and potential complications to patients. And this disappearing tumor phenomenon was a theme of many of these meetings, which made me at least leave with something of an inferiority complex because you wonder whether this is the routine outcome for these patients in other units and whether you're just doing things badly because certainly not all my post-op petroclival meningioma patient scans look like this. Or whether people perhaps don't always tell the truth at these meetings about the challenges that you face. The other thing that I noticed is this series of talks of people putting up these really tough looking tumors, such as these seen in the slides, which we'll talk a little bit more about later. And really being told that, the approach of the person talking to you is better than yours. And again, leaving these meetings feeling somewhat low. But ultimately, in skull base, there are a heck of a lot of approaches, and you can't get expert in all of them. But you will get expert in some of them, and they will become your routine approaches. And to a certain extent, you are best using the approaches that you are most familiar with, most experienced with. Um, but the other thing is that one of the reasons that the field is changing is that now, compared to 20 years ago, radiotherapy, radiosurgery plays a much bigger part. And so the option of leaving tumor behind or potentially not even operating on tumor at all is much more part of the conversation. Um, the transcochlear approach is one that I learnt about really from my fellowship with Ben Panizza in Brisbane in 2008. This was an approach that we hardly ever did in Cambridge, and to be honest, we hardly ever do now. It's arguably the apex predator of the skull base approaches. And I put up a picture of a lion initially and then realized I was talking to the Aussies. So thought I'd throw a great white shark in because that's certainly how many of us think of the transcochlear. It's in terms of complexity, difficulty, time, it is at the top of the tree, but it does give you superb access to the petrous apex and clival region that you can't really obtain with any other approach, certainly no other lateral approach. But I went back and looked at the original paper from Harrison Hitzelberger in 1976, and there were four cases in that paper. Two of them were petroclival meningiomas, and yes, we might still utilize this approach now for a petroclival meningioma. One was a petrous meningioma. I think there are very few people that would use a transcochlear approach these days for a petrous meningioma, and I can't imagine anyone would use this approach for a cholesteatoma these days. And this approach was first put through when CT and MRI were not being used routinely. Patients were being diagnosed on X-ray and post-fossa contrast studies and that type of thing. So it's really an example of how the field has moved. And in Cambridge, we're doing about 100 skull-based tumours a year. About 50 of those are post-fossa tumours, and about 50 of them are anterior middle fossa tumours and sort of central skull-based tumours. And we hardly ever use a transcochlear approach. For the last few years, we haven't done one. I'm sure you're working in units where also at least some of you are working in units that do more. But it's an example of how you become familiar with certain approaches. And while this is a great approach for getting to the petrous apex, there are alternatives. Some of you will take on the types of tumours in this list and with a retrosigmoid approach, or you can get to the petrous apex with an anterior petrosal approach, or with a combined approach, which I'll talk about in a second. And of course, the extended endonasal surgery has also completely changed the field. So what factors do I consider are important in, let's say, addressing a tumor like this, a petrous meningioma? So this is lateral to the fifth nerve, therefore petrous, not petroclival meningioma. And really, I think of them in three groups: tumor factors, patient factors, and surgical factors. So getting as close to as you can certainly helps. And that old adage of removing bone rather than retracting brain is really the fundamental principle of skull-based surgery. And the majority of these tumors that we're dealing with extend into the basal cisterns, and the basal cisterns are littered with arteries and veins and cranial nerves, and you've got to protect those structures. So not crossing the plane of a cranial nerve is a good, um, I wouldn't say it's a rule because it's almost impossible to not cross the plane of cranial nerves for some tumors, but trying not to, if there's an approach that you can stay lateral to the sixth rather than having to cross the sixth or the seventh, for example, is a useful principle. Patient factors. Some patients are very risk averse. They don't want surgery at all, or they're very happy for you to leave a large residuum and for them to have radiotherapy. Other patients are dead against having radiotherapy and they want you to do everything that you possibly can to avoid that scenario. So we need to take those things into account. And surgical factors, certainly as you get older, then comfort is an issue. And I find transpetrous surgery in the posterior fossa much more comfortable position than retrosig. But more importantly, who's on your team? If you've got somebody who's very good at doing transcochlear, that makes a big difference to you working in a unit where you've not done a transcochlear for 10 years, because it's just not practical to decide to use that as an approach. So working within a team is arguably one of the most important things in skull base. And ultimately, you can, of course, optimize the surgery with the right approach. But equally important is tumor consistency and vascularity. And I think coming back to that first slide of those disappearing tumors, you're really dictated to by tumor consistency and vascularity for those cases. You can do a brilliant approach to a petroclival meningioma and then be able to remove almost none of it if it's really fibrous or very, very vascular. So that is something that you cannot control, and it's also very difficult to know what the tumor is going to be like from the preoperative MRI scan. So this is an approach that we've become familiar with in Cambridge, and I just thought I'd show you an example. It's the tumor that we looked at in the previous slide. And so this was a retrolab. The patient had hearing, so a right-sided approach, and you can see the middle fossa dura is being opened here. Posterior fossa dura has been opened. This is just dividing the superior petrosal sinus to give access to the tent. And we like this approach. It's not perfect. There is still a blind spot behind the petrous bone, which is even bigger for a retro lab than it is for a trans lab. But it does take you higher. It gets you very close to the tumor. And if you've got a favorable tumor, you can end up getting, we end up getting nice results most of the time with this approach to our tumors at the petrous apex that really are extending through the tentorial hiatus. If for a tumor that's truly infratentorial, we don't really utilize this approach, but a trigeminal schwannoma or meningiomas are the commonest tumors that we do this approach. But even in our unit, we perhaps only do this 2 or 3 times a year, so it's not something which is common as the tumor just being rolled off the fifth nerve medially. So at this point, I'm going to hand over to Martin, who's going to present a few cases from his practice.
Thanks, Richard. Just on that, I was smiling when you showed that last slide because I think since I did my fellowship in Cambridge, which was back in 2006, I think I've probably done 2 retrolab trans-tentorial middle fossa approaches, but I think I probably did 5 or 6 in Cambridge. So that you certainly do like them over there. It is a really good approach. It seems like a really crap approach when you start. When you cut the tent all the way up to the incisure and it falls away, it gives you a beautiful look all the way up. And certainly can be a really useful workhorse. But yeah, no, it was quite nostalgic watching that. It's been a long time. I'm guilty of employing international skull-based presentation rule number 1 with this case. But this was actually a very favorable case. This was a 16-year-old girl, came to see me really with fairly innocuous symptoms that were unrelated. She had a dizzy spell that was just, teenage girl dizzy spell. I was totally normal on examination, but had this big lump in her head. I might actually just share to my screen so I can use a pointer on the. Can you unshare yours, Rick? Great, thank you. Bear with me. There we go. All right. So large mass, probably arising in the region of Meckel's cave, passing over the petrous apex into the posterior fossa. Large amount of mass effect on the brainstem in a young girl. So decision making, really, the first decision is, do we operate? It was fairly easy to make. I don't think there'd be any dissent in terms of this girl needs an operation.
And do you want to just share your screen?
Oh, I had not. So I thought I did that. Apologies.
Yeah.
1 second.
Just see if you can. There should be a little green button there saying share down the bottom.
Yeah. There we go. Share. You see that now?
Yes.
Great. All right. Thank you. Not terribly au fait with Zoom. All right. Still see it?
Yep.
Okay. Great. Thank you. So likely to be a trigeminal schwannoma in a young girl. Quite why a 16-year-old girl would develop a tumor of this size remains a mystery. She's got no stigmata of neurofibromatosis type 2 and has remained clear of any other tumors that might suggest that or any other signs of it. But clearly something needed to be done. And this is the sort of case where really you have lots of options as to how you can address it. I always remember one thing that stuck with me is I went to the joint section ANS-CNS cerebrovascular meeting in Phoenix back in I was a very junior registrar in about 2003, I think it was. And it was at the Barrow Neurological Institute. And Robert Spetzler was giving a talk about approaches to skull-based pathology. And the key things that I took away from that were the best plan of attack is to plan along the long axis of the tumor and to see where the long axis of the tumor points to. And then to never neglect your easy workhorse approaches, which he talked about the retrosig approach and anterior approach being really the neurosurgical skull-based in inverted comma, if you like, approaches. And you can do probably 70 or 80% of what you need to do through one of those 2 approaches with logical extensions thereof. And so this tumor, when you're looking at it, things that went through my mind are, well, where's the long axis of the tumor? And it's really, can you see my laser pointer? Yeah. So it's really from this point here coming out around the lateral aspect of the right orbit there. And that would lend itself certainly to my eye to coming at it through a temporal polar arterional middle fossa approach, almost if you're coming to the trigeminal ganglion, which is in effect where you're going. other options, clearly you could come through the posterior fossa, decompress the brainstem first, but I don't think that would tackle any of the middle fossa components. That would be committing the patient to a couple of sittings of surgery. Not that there's anything wrong with that. And I'm sure there's other things you could do too. You certainly could do a transpetrous, transcochlear approach, drill this wedge of bone out completely, would give you a fantastic approach to the tumor and would be a lovely way to expose it all. But it would take a very long time, and certainly you'd be sacrificing your facial nerve function. And
Martin,
these,
did you know the diagnosis, or did you just presume that it was something benign?
I didn't know the diagnosis, but I assumed it was probably benign to have got to that size and for her to have been so well. And from where it was arising from, the fact it seemed to have a reasonable plane around a lot of it, I was perhaps hoping it was a trigeminal schwannoma. I didn't have any evidence for that, but that was sort of my diagnosis number one. But my plan was to come through the middle fossa, under the temporal lobe, sort of under the temporal pole, get into Meckel's cave and just see what it looked like. And if it looked like a schwannoma, typically, as we all know, they're fairly surgically friendly, easy to resect for the most part, not terribly vascular, usually got a good plane, and would hopefully have a nice arachnoid plane over the petrous apex into the posterior fossa. And that was borne out at surgery. So before I sort of rabbit on too much, has anybody got any other thoughts as to other ways that they might have as a favored approach to that? Richard, you talked about doing that through a middle retrolab middle fossa transtentorial. Would that be a standard approach in Cambridge?
Yeah, I mean, I think this is a type C tumor, isn't it? And a type A tumor, we would probably, with where the disease is just confined to the posterior fossa, we'd either do retrosigmoid or transpetrous, and predominantly translab if they've got no hearing, or retrolab if they have hearing. For the type Bs, we just do in the way that you would do, and for the type Cs, we'd probably do this combined through the approach I showed in the previous slide, and say, well, the priority is decompressing the brainstem, and therefore get as close as you can to the brainstem and do it through a middle fossa tentorial transpetrous. But that's in part because I don't have a huge amount of experience with what you might call this an anterior petrosectomy, albeit the tumor's done the petrosectomy for you, hasn't it?
And that was the real advantage, was that there's a huge remodeling or scalloping of the petrous apex really compared to the opposite side. And that seemed to be quite a nice, favorable corridor. And I guess we're lucky or unlucky here in Queensland to have a lot of perineural spread disease to the trigeminal ganglion. And so with Ben and James over the years, we've done a lot of approaches, middle fossa approaches to the trigeminal ganglion. And so it was really just an extension of that to get into the tumor. It was something that we're fairly comfortable with, and just have a look and see how friendly it was, with the proviso that I was happy to come back to another approach on another day if required. But that approach coming from the front there certainly seemed to me to be the one approach that would give me the best chance of getting it all out. That was a simple approach. And it was pretty straightforward. It certainly wasn't like a petroclival meningioma. It was just a routine schwannoma, fairly suckable. Got the couche into it, debulked nicely, and had a nice plane around it. Had to peel it off some fascicles of the trigeminal nerve, obviously, but everything else was pushed to the side. The sixth nerve was pushed medially, seventh, eighth pushed posterolaterally, and the bit in the posterior fossa actually was not hard to deliver at all, and the arachnoid plane was well preserved. So that corridor worked out very well on this occasion for this tumor, but certainly it's the sort of tumor that you could easily stage, and the priority, as you rightly say, is decompressing the brainstem and getting a diagnosis. So coming retrosig would equally well have been an option for that, or the middle fossa transtentorial retrolab approach that you showed before. Any comments on that tumor before we move on?
Hi, Martin. It's Damien. Hi, Rick.
Hi, Damien.
Yeah, I thought that last one you just showed, Martin, my feeling with large posterior fossa component tumors, even if they do go forwards, is to decompress the brainstem. And I really like retrosig. And as Richard was saying with his approach, transtentorial, you can still get a fair bit of meningioma or other benign pathology that does loop over the tentorial edge as well from that approach. It's a long way in. It's a little bit tricky, but it is, like you said, a workhorse. So I really like that approach. But I think it was nice to hear you talk about the long axis, because for that one, that's one where I probably would want to follow that long axis and see what happens coming from the front, from a terional.
Yeah.
So that was really interesting. The other one is, like Richard said, the petrosectomy stuff. I haven't had a lot of experience myself with that either, and I feel like it's a lot of work to do necessarily, which I don't know that if you've got a tumor that's done the work for you, you need to worry about. So I don't know what a lot of other people would do, but I like those sort of standard approaches where, you, like you said, you can get most of it done.
The other thing that I think led me to doing it this way was Richard's point about you don't want to cross the cranial nerves if at all possible. And certainly I thought that most likely the trigeminal branches would be pushed medially. Sixth would probably be pushed medially, and 7, 8, and the lower cranials not involved really, but would all be pushed laterally. So coming down the guts of it, down the long axis, really, I wouldn't be crossing anything. And that turned out to be the case. She was one of the few patients that was deficit free. Wouldn't know there's anything wrong with her. Really, just because the tumor had done all the work and had provided a nice logical corridor to come at it down its long axis, and it worked out extremely well. So very favorable pathology, granted, but just underlines some useful principles that you've got some very solid surgical workhorse approaches in your armamentarium, and not to neglect them when you can use them.
Martin, if you had like a different pathology there, like that's a nice soft suckable schwannoma, but if that was a meningioma, and maybe it might not have as much of a middle fossa component because it's not a trigeminal schwannoma, but I think that you're going to it's harder to come from the front and be able to do anything useful with a fibrous meningioma. So
I think if we thought it was a meningioma, albeit it'd probably be in a different age group, it would be very unlikely in a 16-year-old girl. I think probably I would be talking to Ben or James about a trans-Peters approach. If it was all of this but without the middle fossa component, I think that would be very challenging to do through a retrosig. It's a very long way, and you really want a big hole. And that probably would be one. We've certainly done this quite a few times over the years, haven't we, guys? Where we've actually just staged it and done the approach one day, and then you can start the interdural component fresh the next morning, rather than sitting down to start the interdural component at 4 o'clock and running way late into the night. There's a case I've got we can show later on that we staged one that you and I had, James. So I totally agree, Damien. I think if the money had been on it being a meningioma, probably wouldn't have done it that way.
Yeah.
So the question for the audience is, is anyone going to do this anteriorly? So is Richard Harvey on, or?
You mean endoscopically, Ben?
Yeah. I'm not saying I would, but you've got to always look at things. Do you approach things laterally? Do you approach things anteriorly? What is the nature of the tumor? If anything, you're going to approach anteriorly to be a schwannoma because of the ability to debulk it and shrink it down and then peel it out. So I don't think Richard Harvey's on. So Richard Mannion,
I mean,
you do.
Yeah, I mean, we do
anteriors.
we do most of our type Bs endonasally. So if there's little or no posterior fossa component, then we tend to do them endonasal, assuming that the relationship with the carotid is favourable, which it nearly always is. There's usually a reasonable window where these present to the sphenoid that you can, and because the tumours are soft, you can get into the cavity. We do a few of them, subtemporal middle fossa as per Martin's approach. But something where 2/3 of the tumour is in the posterior fossa like this, I mean, these tumours are rare, but B, we don't have a lot of experience of doing those endonasally. And I remember, Ben, in 2008 when we first met Kassam and Karu, and they were proposing doing tumours like this endonasally. And I think their first case took them like 18 hours or something, didn't it? I don't know. How long did this take you, Martin?
Can't remember. We're done by dinner time. Took most of the day.
Yeah.
Not and
but it wasn't bleedy, so it was very favourable. So it wasn't an extravaganza.
Time is not necessarily an important factor. You do the right approach, even if it takes you a bit longer. But there are lateral approaches, such as the one Martin's chosen, that allow good access to this tumour safely with very little morbidity. You need to balance that against your expertise and your experience of trying to do what would be a fairly challenging tumor like this endonasally.
Well,
Richard,
the other point I was going to
say,
make, sorry,
I was
you go,
just going to
James.
say, Richard, the other thing is the instruments that you use endoscopically. I mean, the further you get into the space, towards the posterior fossa, your instruments have to be able to dissect tumor, control bleeding. You've also got to consider the consistency of the tumor. And I find the further I go endoscopically with a lesion, the more difficult it becomes, whereas I don't find that so laterally. So what would you say about that? Do you think that's a factor? Like if the schwannoma was really calcified and difficult, endoscopically it would be much more difficult, I would have thought, to try and debulk that and get it out, unless you had specific instruments that were going to help you.
Yeah, I mean, I think with that tumor, that a bit like an acoustic, isn't it? The most difficult part of the surgery is right at the end of the operation when you're trying to dissect it off the facial nerve. And here, the most difficult part of this tumor is going to be at the end when you're dissecting it off the subarachnoid, the cisternal contents in the posterior fossa. And so your sixth nerve in particular is going to be at significant risk. And that's coming at it anteriorly, whether that be through a middle fossa approach or endonasally, is the longest distance away. At least with the middle fossa approach, you've got a lot of space and you can do proper microsurgery. I've always raised an eyebrow when somebody tells me at a meeting that their microsurgery technique is as good endonasally as it is open, because mine definitely isn't.
Yeah, agreed. One other thing, you mentioned the skull-base caveat before of resect bone and don't retract brain. I think the other neurosurgical caveat is drain CSF and don't retract brain. So because I didn't resect any bone and would have had to retract the temporal lobe, I put an EVD in, and really the temporal lobe just fell away. I didn't have to retract on it at all. So it's just always worth, thinking about, can you, even though the patient doesn't have hydrocephalus, can you use the CSF aspiration to make space for you if you're not going to resect the bone of the skull base. And that really makes it a very atraumatic operation for the patient. So just another case is one that James and I have shared over the years. This guy was quite a bit older, 69-year-old male, presented with this mass with some dizziness and transient vertigo, had a lesion at the petrous apex. Looked a bit like this. Any sort of thoughts on what to do with that one? It's probably a chondroid tumor of some sort.
It looks like a chondrosarc.
junction.
Yeah, it looks like a chondrosarc, Martin. So that's the sort of one I would approach anteriorly looking at it, and it probably is extradural.
Yeah. Well, we didn't actually do anything with this one to begin with because he was so well. We thought we'll just watch it for a couple of months and see what happens. We watched it for a couple of months and it didn't change, and we still haven't done anything with it. And he's 7 or 8 years down the track. It's maybe marginally bigger. That's it now. Sorry, that was then the contrast. That's it now. So it's a little bit bigger, but he's in his mid-70s now. Very well. I think you saw him this week, James.
Yeah, it's grown about a millimeter by a millimeter over about 5 years, and he's got no symptoms.
So we left that one alone. Whether that was the right or wrong thing to do, I'm not sure, but we could easily have made him worse with an operation. But it's probably one that would seem to be favorable coming down the long axis of it there through the petrous apex approach, taking it off the brain stem last would seem to be a sensible way to get at it. But it's behaving in a very benign, indolent sort of way.
Richard, what would you do in this situation? The guy's sort of 70 odd. If you had to operate, would you want to go laterally or endoscopic for him? I mean, you're not looking at the whole lesion, but
yeah, I mean, so this is the tumor in the UK that we will send for protons, and you send it down to the proton panel, and if there's any residual tumor afterwards, they send them back and tell you to do more surgery, which can be a frustrating exercise. And that's particularly the case if there's any tumor within 2 millimeters of the brainstem. So if you're going to operate on it, then either you're going to accept that you're not going to send it for protons, and there's perhaps a debate there to be had. But if you are, then you've got to prioritize decompressing the pons. This is a difficult tumor. The ones that I see like this, they tend to present with a sixth nerve palsy. And so, you don't need to worry about the sixth nerve so much. But here, it's hard to know where the sixth nerve is going to be. So we know where this tumor started. It started in the sort of petrosphenoid recess. But has it pushed six lateral? Has it pushed six medial? Is six going straight through the middle of it? And he hasn't got a sixth nerve palsy. And that's a horrid morbidity to give someone from surgery. So you would need to counsel them about that. But the good thing about these tumors is that they're usually very soft and they come to you and they go up the sucker quite easily. And so, although that lateral disease in the petrous apex is going to be quite difficult to get direct access to with an endonasal approach, we would probably come endonasally for this, if we were going to operate on it. But as Martin's demonstrated, while the oncologists get very excited about chondrosarcoma, chondrosarcoma in the elderly is a fairly benign disease. And they often grow very slowly over many years, and you've got to balance that against the risks of however you approach this, it's going to be a big operation.
Ben, I think we had one of these a few years ago that we did. It looked pretty similar to that, and we did the retrosig debulking and decompression of the pons, and then tried to sort of, because it was soft and suckable, as Richard had just said, we just sort of sucked out some of that stuff that we could reach forward in the petrous bone, and then with a plan to either come back anteriorly endoscopically and leave a little fat graft there as a marker. Do you remember that one?
Yeah, I think that's reasonable, Damien. The morbidity is from the compression of the brainstem, and the residual that's in the skull base. You can watch, see what you want to do.
Probably a good one for gamma knife as well. You could just take out do a simple retrosig, take the spit out, and gamma knife the rest. Would be reasonable. A fairly elderly guy.
Yeah, and you can give them a margin on the brainstem and anything else, but. Like you said, Richard, where is the sixth nerve? It's a bit of a mystery and a risk.
Yeah. This is just a fairly quick one, just to demonstrate the big hole that you can make with a transfetrous sort of transcochlear approach. This was a guy presented to an ENT surgeon in town with unilateral left-sided hearing loss and had a large contrast-enhancing mass in his posterior fossa. Looked like it was going to the jugular foramen, so most likely a lower cranial nerve schwannoma, a very large tumor. Didn't have any CSF playing around it, and this was one that we elected to do through a transcochlear approach and staged. So James did a drill out of this in one day, gives a nice corridor here, and then we did the intradural approach the next day. It was very vascular as well. We knew that ahead of time. We'd done an angiogram because there were a lot of phloboids in it, and I was concerned it might be a glomus tumor. And we actually embolized it ahead of surgery, which made it a lot easier to work with. And there was a subtotal resection. There was certainly some residual left inferiorly that I couldn't get to, which has slowly grown over the years, and he's had gamma knife to that residual as well. But there's no, I think I've always been very happy with the results of staging a transcochlear approach one day and doing the intradural component fresh the next day. I hate sitting down late afternoon to start what's going to be a mammoth operation. I don't know what people in other centers do, but I would be a big advocate for staging that sort of surgery.
So, Martin, was the jugular bulb gone in that case, given that it was a lower cranial nerve schwannoma? Was it a schwannoma or meningioma? It
was a schwannoma, Ben, and it wasn't. No, it was still patent. It was a bit squished, but there was still some flow in it.
It's a 12th, is it?
I can't remember now.
It looks low enough to be a 12th.
Yeah, it could have been.
The CT would show you where it comes from.
Yeah.
Now, the other reason I make that point is that when you do have the lower cranial nerve schwannomas, if it's already knocked off the nerve, almost always the jugular bulb's gone. So you do the petrooccipital transsigmoid, which is very similar to what Richard showed before with the classic transpetrosal transtentorial approach, where because the sigmoid's gone anyhow, you're basically doing a pre-sigmoid retro labyrinthine approach combined with a retrosigmoid approach, and that gives you quite a good corridor without having to move that facial nerve.
But as Richard pointed out earlier, it all comes down to the collective team comfort level with your approach that you're facile with, and certainly units that don't do a lot of translabyrinthine or trans petrous bone work, you could easily approach that through a retrosigmoid approach. Cerebellum would take a bit more of a pummeling, and certainly coming through the petrous bone gives you a much better corridor at it. But certainly the old workhorse retrosigmoid approach, there'd be no shame in tackling it with that, albeit there's a lot more retraction involved.
That's also the long axis of that tumor, as you said before, Martin.
Yep.
So, Damien, you like retrosigmoid. You wouldn't approach that retrosigmoid, leave the bit in the foramen, the 12th foramen, and just watch it or gamma knife the residual? That's a question for you, Damien.
Yeah, Ben, that probably would be my first instinct. That's what I'd feel like doing, and particularly if you're already planning on leaving a residual, then and you've got gamma knife as a backup, then yeah, there's not a lot there that's you wouldn't require a lot of cerebellar retraction if you do good CSF aspiration or couple it with a lumbar drain or an EVD. So I've found that to be quite a useful thing, yeah.
And in terms of controlling any potential hemorrhage or damage to vessels, Martin and Damien, that transcochlear versus a retrosig approach?
I think controlling hemorrhage through a big hole is always easier than a small hole. And if you get any cerebellar swelling, you rapidly lose your vision coming retrosig. And I think that was probably my thinking when we discussed this and decided to come through a transcochlear approach, because we just really wanted as big a hole as possible, with as many angles as possible to get the top bit and the bottom bit. In the end, I couldn't get this bit here, just sort of ducking over the corner of the bone. That was almost impossible to reach safely. And that was the residual that subsequently grew. But it was a very vascular tumor on the preoperative angiogram, and I just wanted all my ducks in a row and as big a hole as possible.
Martin, I can't remember, but do you think the embolization made a difference for this one? Because we don't tend to embolize schwannomas very often.
We don't. Well, I think it did, because I can't remember in which order we did it now. I think we did the angiogram and then we embolized it, and then the following day you did the transcochlear, and then 2 days after that I did the intradural component. And when we did an interim scan between your drill out and my intradural component, and it was full of holes. So it was starting to necrose quite dramatically, and it wasn't vascular when I went into it. I don't know what it would have been like had we not embolized it, so it's hard to tell. But I think it probably made it easier. It's not something that we would normally do, as you say, for a schwannoma, but I didn't know what the pathology was beforehand. I thought it might be a glomus tumor, and an angiogram seemed like a sensible thing to do in that situation. What do you typically do, Richard, when you've got tumors in this location and a glomus tumor sort of goes through your mind? Would you get an angiogram and embolize them?
Yeah, I mean, this is one of the areas which has changed completely. I know when I started in Cambridge, my senior colleague who was doing all the acoustics said, I'm really pleased to have you on the team, but I just want to let you know I'm doing the acoustics. So if you want to do anything, I suggest you specialise in glomus tumours. And I think in the last 10 years, we've operated on 2 glomus tumours, and one of them turned out to be a misdiagnosed vestibular schwannoma. So the field has completely changed, hasn't it? That the natural history of these tumours is very benign, and radiotherapy plays a much bigger role. So a tumour like this, you'd immediately think it was a lower cranial nerve schwannoma, but you can get meningiomas that look just like that and go through the jugular foramen or the hypoglossal foramen. And so you don't really know. If you knew it was a meningioma beforehand, then at least you know that the cranial nerves are likely to be on the capsule, which makes surgery a little bit more attractive. If it's a lower cranial nerve schwannoma, you don't really know where the lower cranial nerves are going to be. And so if they're not presenting with lower cranial nerve palsies, and quite often they're not, then that is a big morbidity. That is a big hit for a patient to end up with, a trachea and a peg, which, is something that you have to consent them for. if you're going to go into this. So if we were having to approach this and we weren't sure what it was, then it would, and they didn't have a bulbar palsy, then it would very much be an attempt at a subtotal resection, and it would either be retrosig or probably transpeterous, just because we do the vast majority of what we do is transpeterous, and as I was saying earlier, it's a much more comfortable position. You're not going to get in trouble with the cerebellum. You are a little bit closer to the tumor, so that's how we would approach this here.
Well, I'll hand it back to you, Richard.
Yeah. So the question before about dealing with a vascular problem through a small hole rather than a big hole, and whether I would choose retrosig or something more extensive like a transpetrous, I sort of think about it more so from what am I going to be able to do with the tumor, and a soft tumor. If I know it's a schwannoma or it looks or gives me the impression that it's going to be a more suckable meningioma, then I'm pretty comfortable with retrosig for those reasons. That once you're in there and you've got CSF off, you can debulk and roll the tumor, but anything that sort of looks obviously harder, calcified meningioma, and I can think of one Ben and I did a few years ago where it was pretty much a stone against the brainstem off the petrous apex, and so we did a transcochlear, and that was staged, which was probably one of the 2 or 3 transcochlears I've been involved in, and they're the ones where I think you just need all the space you can get.
Yeah.
Right. Can everyone see my screen? Can everyone see a screen?
Yes.
So we're nearly done. You'll be pleased to hear. I thought we talked a lot about tumours through lateral approaches. I thought we just finished talking a bit more about central skull base tumours. And so, there's more than one way to skin a cat, but really when it comes to a tumour like this, a chordoma in a young patient, you can only approach this centrally. The skull base is guarded by this century of neurovascular foramina, which contain the nerves and arteries that we do not want to injure. And so for a tumor like this, you've got to come through to this centrally. But this paper that you're seeing the cartoons for here was published in 2007, which was just about when I was packing my bags to come over to Brisbane. This is not surgery I'm familiar with. It's not surgery I would ever want to have or do. But around this time, the field was being revolutionized by this guy who I'm sure many of you know on the left, Amin Kassam, and of course colleagues in various centres, but Pittsburgh was a hotbed in the mid-noughties. He's here still with one of my ex-colleagues, Ramesh Kiralos, who I'm sure many of you also know. He's now working in Singapore and is an amazing skull-based neurosurgeon. And Amin and colleagues really completely changed the field of central skull base surgery with their tour de force breakdown of the skull base based on anatomy and safe surgical approaches. And shortly after I started as a consultant, this young girl came into our clinic. She's 8 years old. She's been diagnosed with this tumor. We looked at the tumor in the MDT in the morning, and heart sink moment, because it looks very much like a chordoma, but it crosses my mind, how are we going to get this tumor out without causing this little girl a lot of harm? And when she then came into the clinic, I was at least hoping or half expecting that she would have lots of symptoms and a stiff neck and not able to do this, that, and the other. And she really had no symptoms at all. She was making a bit of a mild snoring noise at night, which is why her mum had taken her to her GP, and it culminated in this scan. So this girl was pretty much perfect. She was still playing football, doing gym, going to school. She had no neck pain, full range of neck movements, which again makes you think, how are we going to get this tumor out without causing her harm? This is just a CT to show the damage that this tumor has done to her lower clivus. So all of her ligaments between the lower clivus and the top of the spine, the odontoid, will have gone. Half of the occipital condyle on the right-hand side has been eroded. And you wonder how you're going to get this out without causing major craniocervical junction instability. So this is sort of how we broke down the tumor. So in the sagittal plane, we tried to work out how much of it can we get endonasally, and thank goodness for the endonasal approach for tumours like this. And of course, because these tumours are soft and suckable, it lends them to an endonasal rather than an open transfacial approach. You are limited by the hard palate, which is what the line it depicts there. But equally, because these tumours are soft and because you can put something in the mouth to push up the soft palate, you can often deliver these tumours without having to go through the mouth, although sticking the scope into the mouth is no big drama if you have to do that. We didn't want to do one of those, and we wanted to try to do this without having to do a craniocervical junction fixation for two main reasons. Firstly, it's a horrible thing to do to anyone, but particularly to somebody who's got normal neck movements. Secondly, if you do this, you can't have protons. And so our proton panel in the UK can't do their planning because of the artifact that you get from the implants. And so there is an onus on trying to get these tumours out without putting instrumentation into the spine, if at all possible. And so this is the rule number one of the international meeting. So top is pre-op and bottom is post-op. And we did this through an endonasal approach, and we were able to get good removal of tumour all the way back to the craniocervical junction. And this little line here is the transverse ligament. And so you can see on the bottom scan that the odontoid is just in front of it. And we had great view of the odontoid, and we could see the transverse ligament. And I did not want to take the transverse ligament because I was pretty sure if I did take that, then this girl would be left with craniocervical junction instability, having already lost much of the structures that keep the head attached to the top of the spine. And so we went into this surgery with the expectation that we would be leaving this nodule of tumour in the spinal canal behind the transverse ligament. And this was the immediate post-op scan. But we just came back at that a week later through a right-sided hemilaminotomy approach through the C1 lamina, and were able to achieve a gross total resection through this combined approach, respecting the anatomy and therefore reducing the morbidity of our surgery. But of course, the key factor here was that this was a soft tumour, not that we were doing anything particularly brilliant with our instruments. So we got away with it without having to fix the head to the spine. She had normal neck movements post-op, and she went off and had her protons, and she's about 2.5 years out now and is disease free. Is she stable? She seems it at the minute. Is it going to last? I don't know. Her mum recently updated me on how this young girl is doing and sent me this video from their holidays, which is not what you want to see when you're worried about craniocervical junction instability. But she seems to be doing okay at the minute. It's possible that we might end up needing to fix her at some point in the future, particularly if she carries on with that sort of an escapade. So this is just a final case, and again, it's just to remind us all about the natural history. So this is a lady that presented a long time ago to our service. I was still a trainee with this peteroclival meningioma, and the beady-eyed of you will notice that the tumour on the right, it looks a bit bigger, and that's because it was a follow-up scan 3 years later. We advised this lady that she should have surgery and that she was going to come to harm without surgery. She did not want surgery. She had young kids, and she was very frightened about the risk of surgery. At that time, our oncologists were not keen to give her radiotherapy because of the degree of brainstem compression, and so we have just watched this tumour over the years, and it has, as per the natural history of meningiomas, got bigger. But she has remained pretty well. She's got more symptomatic. Her balance is not great, but she's ambulant. She is still a mom. Her kids are now into their 20s, and she's still not letting us anywhere near her. So, you know, there's a debate about the natural history of these tumours. Some people say 50% of them don't grow. Other people say if you do volumetrics, all of them grow. And you know, most of us sit somewhere in between, I think, of that spectrum. But there's no doubt that the natural history is generally favourable for the majority, and the risk from surgery for peteroclival meningioma, certainly in Cambridge, you know, this is where we see our highest incidence of complications associated with surgery. So it is a major thing to have to operate on. So always remember that you do have time. These days we are now blessed, or we have radiotherapy, whether that be fractionated, which we use a lot of in Cambridge. Certainly for a tumour like this, we would never treat this with single fraction. It would always be fractionated radiotherapy. But the gamma knife is revolutionising the field. So at this point, I'll just hand back to Martin.
Just unmute yourself, Martin.
Thank you. Yeah, so as we both said throughout, the approach really is dictated by where the tumor is, what you think it's likely to be, patient factors, and really what you're familiar with and what's in your comfort zone, and working out a plan that works best for your institution and the resources that you've got and the team you've got, and the best way through it all. And those caveats that I remembered from that talk with Spencer, which was a long time ago, and I really use the simplest approach you can. Use your workhorse corridors that you're familiar with. Try and minimize the number of goes you have to have at a particular pathology, if at all possible. And remember, the long axis of the lesion usually takes you down the guts of it, and the important structures are normally pushed to the peripheries. So look where it points, look at the long axis, and can you get an easy approach down that long axis that will solve most of your problems. And as Richard was talking about before, and James spoke about, really the limitations of your instrumentation. This comes back to your own surgical comfort zone. Are you as happy doing a fine dissection, trying to peel arteries off the back of a tumor endoscopically as you are with open surgery? Depends a lot on your instrumentation and your surgical comfort level and training. So it's horses for courses, but certainly just a few rules to stick to try and minimize problems.
Excellent. That's a fantastic summary of what we have to deal with every day, really, in our everyday lives. But does anyone who's listening, does anyone have any questions they want to ask our speakers tonight before I close? Or anyone want to make any comments? Okay, well, the webinar will be recorded. So for those of you who want to go back and look at it later, you're very welcome. Just go to the website. Can I thank Richard and Martin again for your contribution, and also for our other members who contributed tonight. Thank you very much. And we'll see you in 8 weeks' time for our next talk, which is going to be on paediatric skull base. So until then, thank you and have a good evening.
Thanks, guys.
Good night, everybody.